Assalamualaikum and good day to everyone. I'm Dr. Nuruda Ahmad, lecturer and emergency physician from Universiti Teknologi MARA. In this lecture, I will be talking about the concept of triage. Triage is unique to the emergency department. Triage is a method of systematic prioritizing of patients that come to the emergency department. An effective triage reflects a well-functioning emergency care system, especially when there is surge of patients. These will be the learning objectives for you. At the end of the lecture, I hope you will be able to understand the principles of different triage systems, describe the component of triage categories, describe the triage process in hospital, and to perform triage for patients presented in emergency department. This will be the content of my lecture. We will start with definition and talk about the challenges of doing triage. Then we will discuss further on hospital triage and a bit on disaster triage. For each type of triage, we will look into some of the examples. Okay, let's start. The word triage originates from the French verb, which means to separate out. In other words, to describe triage are to prioritize, to sort, or to sift. Or in Bahasa Melayu, it is known as proses saringan. The best way to describe triage is actually to sort out patients or casualties and to prioritize depending on the severity of their condition. Triage originates from World War I. It evolved from military procedure of identifying wounded soldiers who could be treated rapidly and expected to benefit the most so that they can return to the battlefield. This concept has been adapted and accepted as a practice all over the world. What is the objective of performing triage? What is the purpose of us doing this? Triage ensures that the unstable or the potentially unstable patients are seen and treated urgently. It also ensures that those who are unlikely to deteriorate could wait safely for their care. Triage is a concept where you prioritize patient, you provide immediate critical care if needed, and do the most for the seekers with available source. Like any other system, triage also has its own challenges associated with it. One being wrong triage. As triage is dynamic, patient's condition can sometimes deteriorate from the first person seeing the patient to the second person seeing the patient. Misdiagnosis also often occurs because triagers only see patient very briefly and do rapid assessment. Sometimes their impression is not the same as what the patient actually have. Substandard pain management. There are limited numbers of analgesia that can be given at triage. Drugs such as opioid cannot be given there. Therefore, sometimes the analgesia that can be given from triage is not enough for patient. Substandard knowledge on triage, even among triagers. That is another challenge, and it is pretty much self-explanatory. Stable patients or non-critical patients may need to wait long in the waiting room before they can see the doctor. Sometimes this will lead to anxiety and dissatisfaction, and the person that they go and search for are the ones in triage area. Not only triage person need to triage new patients, sometimes they also need to deal with patients or relatives who are waiting. Emotional instability of patients. Again, as mentioned before, patients or relatives may be scared, anxious, and angry, which triage person may need to deal with. There are three types of triage. Number 1, phone triage. This is telephone contact where the triager asks questions to estimate the urgency and the necessary care level, whether the patient can be managed at home, need to seek outpatient clinic treatment, or to bring in to the hospital urgently. Number 2, hospital triage. This is where triage and rapid sequence examination are done at the various zones of patient management in the emergency department. Number 3, disaster triage, where the number of casualties overwhelm the capabilities of the on-scene care provider, usually the paramedics, and resources at the nearby facilities. In this lecture, we will focus more on hospital triage or the ED triage, and we will touch a bit on disaster triage. These are pictures of where each of the triage takes place. If you see the ED triage, there are few patients lining up outside the triage area. Most of the patients are on their feet, ambulating, indicating that most of them are not critical. Furthermore, they are at the hospital facility where the resources are readily available to treat any critical patient. In contrast to the picture on the right side, there are several patients lying on the ground, clearly not ambulating, indicating that their injuries are probably much more severe. The incident happens by the roadside, in which their resources for their medical care are limited. So the approach to triage these patients are different because the circumstances are not the same. Apart from the differences that you could see in the previous slide, other point that differentiates ED triage and disaster triage are as shown. ED triage is static, means that triage decisions are made at single point in time when the patient comes, whereby in disaster triage, the triage is dynamic and occurs at multiple points in time. There are fewer patients in ED at one time as compared to disaster, where you have many patients at one time, and this correlates with the availability of resources to manage these patients as well. In ED triage, the aim is to identify critically ill patient who requires immediate care. The most critical will get the highest priority for life-saving care. Different in disaster triage, the aim is to do the greatest good to greatest number of casualties, which means most of the time, the sickest is not the priority. We need to use available resources efficiently to treat as many as possible patients who have the chance of survival. Okay, let me give you an example. If you have a patient who's gasping, came to the hospital, this patient will get the highest priority and will be triaged to red zone and given immediate care. Say if you have a patient similar gasping after a bomb blast, this patient may have least priority because even with life-saving procedures, patient may not survive. Therefore, resources are better channeled to other casualties with higher chance of survival. Okay, now we will discuss hospital or ED triage. The principles of ED triage is to classify patients according to the type and urgency of their conditions, to get the right patient to the right place at the right time with the right care provider. The process of triaging in ED starts when the patient arrives to the hospital. They can either come in by themselves or via ambulance. Regardless their mean of arrival, all patients will have to be seen in primary triage first. In primary triage, patient will be assessed and unstable or potentially unstable patient will either go straight to critical area or semi-critical area. Stable patients will go to secondary triage. In secondary triage, they will be further assessed and then triaged to either critical, semi-critical or non-critical zone. After receiving acute medical care, this patient either will be admitted or discharged home. This is the process that every patient will have to go through when they arrive in ED. According to Malaysian triage category, there are 3 zones of patient management in the emergency department. Red zone or critical zone, Patient here is to be seen immediately as they may require immediate life-saving intervention. Yellow zone or semi-critical zone. These patients are high risk of becoming unstable. Patients here should be seen within 30 minutes of their arrival. Green zone or non-critical zone. These patients have secure airway and hemodynamically stable. They should be seen within 90 to 120 minutes. There are also subcategories within the green zone. These are some of the examples of patients' presentation according to triage zone. Patients who are hemodynamically unstable, polytrauma, patients in shock, GCS below 13, or patients presenting with ongoing severe chest pain should be triaged to red zone. Whereas, those triaged to yellow zone are those who are hemodynamically stable but unable to walk, those with severe pain, patients with lower limb fracture, poisoning patients, GCS below 15, or stroke patients as they are unable to wait on the wheelchair. Other presentations may be able to be in green zone. Within green zone, there are subcategories. G1 is fast lane for patients requiring early treatment given before consultation with doctors. G2 are those requiring some sort of procedures and should be seen within 60 minutes. And the rest are either G3, 4, or 5. There are two levels of triage, primary triage and secondary triage. Primary triage usually are stationed at or near the entrance of emergency department. From here, they may assign patients straight to red zone or yellow zone based on their assessment. Patients who do not satisfy the criteria will proceed to secondary triage for further assessment. Some non-urgent or non-emergency patients whose issues can be addressed at specialist clinic or primary care clinic may be triaged away. The aim of primary triager is to identify critically ill or injured patients and divert them immediately to treatment area. The role of primary triager is to perform critical first look and rapid assessment. Critical first look is a quick observation of the patient to determine rapidly if they require resuscitation. Rapid assessment looks for respiratory distress, state of shock, and decreased conscious level or active bleeding, which require resuscitation. Secondary triage is usually conducted in a room or cubicle by staff nurse or medical assistant. Here, secondary triager will perform further assessment and take brief history. They also perform first aid for patients such as dressing and bandaging. From here, patients will be sent to any of the zone depending on the assessment in secondary triage. The aim of secondary triage is to perform additional assessment of patients who initially deemed stable at primary triage and divert these patients to appropriate area. In secondary triage, triage officer will take vital signs, perform simple bedside tests like ECG or capillary glucose level if appropriate, take brief history to identify red flags, and do simple procedure if necessary. Okay, next, let's see some examples on how to perform triage on patient. We have here our first patient, a gentleman in his 50s. He walks up slowly towards you and complained of chest pain started 30 minutes ago. As primary triager, you perform critical first look and rapid assessment. You observe that this patient is clutching his left side of chest, breathing heavily, and sweating. Now, what goes through your mind? It sounds like he is having acute myocardial infarction or heart attack. With his current condition, he may collapse anytime if treatment are not given immediately. Therefore, this patient should be triaged to red zone immediately. Once you settle transferring patient 1 to resus, you came back to primary triage and finds that an ambulance just arrived at the patient drop-off area. Your patient 2 is a female in her 20s with pain over her right leg after a motor vehicle accident. You quickly perform critical first look and rapid assessment. She is in distress with severe pain. She has an open wound and swelling over her shin. Her injury seems to be isolated to the right leg, but she is unable to ambulate on her own and she needs medication to help with her pain. Therefore, this patient should be triaged to yellow zone to receive her treatment. Incoming your third patient, a gentleman in his 30s. He walks up to your primary triage looking rather calm. He complains of abdominal pain since morning. Your critical first look and rapid assessment does not show that the patient is in any obvious distress, although he looks slightly lethargic. Now, where do you think this patient should be sent to? Since on the first glance, he seems to be stable with secure airway and does not seem to be in a state of shock, he may be able to be sent to secondary triage for further assessment. In secondary triage, his vital signs and brief history were taken. His vital signs are as shown. His pain score is 2 out of 10 and he has underlying gastritis. Now, where do you think he should be triaged to? It would be appropriate to triage him to green zone. He could probably be given a G1 level and be given some gastritis treatment such as syrup MMT before seeing the doctor. Alright, that's ED triage for you. Now let's move on to disaster triage. We will only discuss briefly on this topic to see what it is. Before we discuss further, we need to understand what is disaster. What defines a disaster? It is a situation that places a significant demand on medical resources and personnel. For example, following a hurricane or typhoon, or after a bomb blast or explosion, where there is significant number of patients at the same time, and these patients require urgent medical care which may be overwhelming for the nearest medical facility to handle. That defines a disaster. While natural disaster may not occur often, mass casualty incident occurs more often than you expect. Mass casualty incident also utilize disaster protocol and triage system because it is also a situation that may overwhelm local medical facility. Here in the picture is an accident involving 2 buses. If the buses are full of passengers, you can imagine the number of people that are injured in this accident. This may easily overwhelm the nearest hospital if they are to receive 20 to 40 patients all at the same time. Furthermore, how many ambulances are there to transport the patients? Which patients should be transported first? How do you make that decision if you are the first ambulance team to respond to this area? Can one ambulance team handle to treat the large number of casualties? The principles of disaster triage is to do greatest good to greatest number of patients while using the limited resources. Use the limited resources to those who will benefit the most. In disaster triage, there are 3 categories of patients. 1. Those who will die no matter what we do. 2. Those who will do well no matter what we do. And 3. Those who will get a long-term benefit from acute intervention that we give at the scene. Triage process in disaster utilize the START algorithm. Simple triage and rapid treatment. Start. It is performed by the first responder to the scene, usually the paramedics. It follows the concept of RPM. R for respiration, P for perfusion, M for mental status. Only these three things are assessed to triage the casualties. This is the START algorithm. Patient will be assigned to different colored tags. Black tag are those who are dead or have such extensive injuries that they cannot be saved with limited resources available. Red tag, those whose lives are in immediate danger and require immediate treatment. Yellow tag are those whose lives are not in immediate danger but will require urgent care. Green tag, those with minor injuries who will eventually receive treatment. The triage starts with separating all walking wounded to the side or a designated area. These are the green tag. By doing that, you will be able to see more clearly which patients you need to perform triage on. First, assess the respiration. If patient is not breathing, open their airway. If there is no respiration, they are black tag. If there is respiration after you open their airway, this patient receives red tag. If patient is breathing, observe their rate. If it's over 30 per minute, they receive red tag and require immediate treatment. If the respiratory rate is less than 30, check for their perfusion. Absent of radial pulse or CRT of more than 2 seconds, patient is red tag. If perfusion is good, check for mental status simply by assessing if they can follow simple command. If they cannot follow command, they are red tag. If they can, they are yellow tag. So this is how you perform START triage. Okay, now let's try with a few examples. First example. There is a big fire in a building and many casualties. The patient is 61-year-old, complaining of difficulty breathing. His respiratory rate is 28, his radial pulse is palpable, and he can follow simple command. What tag should he receive? Okay, let's see the algorithm again. His respiratory is less than 30, his perfusion is good, and his mental status is good. So he receives yellow tag. Example 2. A bus skidded and crashed on its way down from Genting Highland. One of the patients is 31-year-old male, complaining of pain of both thigh with bleeding. His respiratory rate is 28. You cannot feel his radial pulse, but he is able to follow simple command. Which tag should he receive? Oh, he is not tachypneic. His perfusion is poor, but his mental status is still good. So he receives red tag. Example 3. A building has collapsed. There is an 18-year-old female trapped under the rubble and she was rescued. On assessment, her respiratory rate is 24. You can feel her radial pulse, but she is unable to follow any command. Which tag should she receive? Her respiration and perfusion is good, but she has poor mental status. So, she should receive red tag. Those are some of the examples on how disaster triage is performed. As conclusion, we recap some of the differences between hospital or ED triage and disaster triage. Hopefully, this will make better sense to you now that we have discussed it and saw some examples. ED triage is static at one point of time. there are fewer patients and your aim is to identify most critical patients to receive immediate care in a timely manner. As for disaster triage, it is more dynamic, involves large number of patients, and your aim is to do greatest good to greatest number of casualties, even when it means you cannot treat everybody due to the limited resources. Now that's the end of my lecture on triage. If you have any questions, feel free to drop me an email at huda8317@uitm.edu.my, or you may contact me directly via text messages. Have a good day.